Thanks a lot. Allow me to express my sincere thanks to the organizers, as well as to the Green Crescent organization for this invitation and all the people working for this symposium. I really appreciate the kindness and the luxury you offered us. I will try to discuss about my country. I hope I will be in time. And allow me to say that I will try to go from theory to action. Which one?
Here is next.
Okay. We are under economic recession, and it's not only in my country, it's all over Europe, all over the world. Studies on economic crisis and their consequences show a relation between mortality and morbidity trends and the capacity of health systems to respond to increased demand for care. The impact of the economic crisis on health determinants is also related to increased licit and illicit drug use, as well as problematic use of drugs. And you can see in these slides what was the GDP growth with the red line on the European Union and with the black line on the world, and also the influence on unemployment, the rate in European Union, and the red line concerns the youth and the other the total population. Pictures like this are obvious. We know the impact of the economic crisis on mental health. And just a slide showing the influence of economic crisis on drug use, and we mean the trends in drug use, in trends in health consequences, trends in crime development, trends in social exclusion, and also the influence on drug policies, on the impact on availability and funding of services, impact on accessibility of services, and impact on quality of services. And if we speak on drug use, the influence of economic crisis on drug use, we mean the risk of an earlier onset of drug use. We have increasing prevalence of injecting use, more relapses, risk-taking patterns, overdosing among vulnerable groups, increasing incidence of polydrug use, as well as increased criminality. And if Europe has economic crisis, in Greece things were worse. The economic crisis is linked with social and political crisis, which lead to decisions. However, the impact of the economic crisis is asymmetric, as often doesn't affect the whole country or all population groups, but only some regions, towns, or subpopulations, usually the most vulnerable. Let's see the Greek experience, example of a country facing austerity measures. We know that there are variability on HIV infection and HIV transmission patterns in Europe. Most countries have experienced stable or declined trends in the annual number of new diagnosis cases of HIV among people who inject drugs. There are countries in the European Union, Greece and Romania, experienced large HIV outbreaks in 2011 and 2012, while rising numbers have also been observed in Bulgaria since 2006. Let's see what was the situation concerning drug policy in Greece in 2010. We had 74 therapeutic programs all over Greece. 25 of those were OSTs, 43 were drug-free programs, 6 were in the prison environment, and we had almost 8,000 drug users under treatment. In 2011, Greece faced an outbreak of HIV epidemic among people who inject drugs. It's true here that it was not all over Greece, it was mainly in Athens, and this was a consequence of both the socio-economic crisis and the long waiting list for substitution treatment with limited access to the treatment and harm reduction services. Overconcentration of active drug users in open drug scenes were also observed in certain areas in Athens. Contrary to a repression approach, it was promoted a cooperation of all the specialized agencies towards the adoption of measures to protect public health and safety. You can see pictures like this, not only in Athens, but in a lot of European cities. And here, there are the numbers. The red numbers is the total HIV cases per year, and the blue numbers represent the new HIV cases among people who inject drugs. It's obvious here that even though from 2000, the number of new cases among drug addicts were less than 20 each year, in 2011, we have much more cases, and this was the case for 2012. And here we can see the same slides by high-risk groups, I mean men who have sex with men, usually the blue color, and then the red color is for drug users. And you can see also that for first time we face 666 new cases in 2011 and 547 cases in 2012. And things were better next year. So, what were the main targets and what was the new national drug policy to face the situation? We had to increase the treatment availability with new OST units within the state hospital. This is very important. Usually we had drug addict units, therapeutic units outside the hospital. And this, of course, is a matter of stigmatization. And also, we have to increase the existing health promotion intervention, women needle syringe programs, exchange of needle syringe programs. And then we have to act for special drug population groups. I will not go in details on these slides. I just want to show you that within 4 years, from 2010 to 2013, the total OST units from 25 became 53, and the total number of patients taking treatment from 5,100 became 8,200. Of course, you can see here the distribution among the different cities in Greece. More units in Athens. We have half of the population living in Athens. In Thessaloniki and in other cities, we are back for the cities outside Athens and Thessaloniki. Of course, the OST demand declined with the new units. The waiting time, believe it or not, the waiting time in Athens was almost 90 months, 7 years, for a slot, a therapeutic need, and now is still high, 43 months. This is not the case in Thessaloniki, where the waiting time was 4 years and now is only 2 months. And you can see here that almost 81% of all the patients are taking OST treatment. 14% are on therapeutic communities, 3% take therapy in the prison environment, and 2% are under detox. Here is a slide coverage of needle and syringe per year. We have a very high distribution during the last years, but we didn't reach the recommendation. WHO recommend that per patient per year we have to distribute 200 syringes, but now from 7 syringes we manage to distribute 140. It's impressive to see the decrease of deaths because we put a lot of addicts in treatment. I don't want to see what other measures we have taken, but I have to mention that we started OST programs in the prison environment. We started alternative to imprisonment techniques. This is a picture from the prison environment. I hope this will not be the case in the future. It's not only, it's also this that takes us time, believe me. As I told you, in September 2014, we started the first program, OST program in the Greek environment. And here is the last one, just before the last one, the slides, that I want to show you. The red line is the budget that we distribute for drug addiction, for the services I mentioned, and the blue line is the number of patients. So we can see that with 50% less funding, we almost doubled the number of taking treatment. I will pass the slides concerning the effectiveness, cost effectiveness. It was not mentioned at all that we don't have the luxury to invest as money as we want on drug policies. So we have to make some decisions, and allow me to conclude with these proposals. We have to ensure essential services. We have to decide about priorities. We have to invest according to cost effectiveness. We have to compact to opposed stigma and discriminalization. We have to invest on building social support and recovery networks. We have to strengthen national and international cooperation. We have to involve the patients in our therapeutic contracts. We must have less war on drugs, more human approaches, and less ideology and more science. Thank you.